Psychoactive substances are chemicals that affect the mind, altering mood, perception, or consciousness. These substances can be found in nature or synthesized in laboratories. Let's begin with a truth that gets buried in most drug policy classes. Humans have always used psychoactive substances. From the coca leaves of the Andes to the poppy fields of Mesopotamia, psychoactive plants have played central roles in healing, spirituality, and social bonding. The use of substances like cannabis, opium, coca, and psilocybin wasn't criminal. It was cultural, it was sacred, it was medicine. In South America, the coca leaf has been a part of indigenous Andean life for thousands of years. It helps with altitude sickness, hunger, fatigue, and it's chewed in ceremonies, not smoked in secrecy. But when Western colonial powers arrived, they didn't respect these traditions. They feared them, and that fear became law. Colonialism, the practice of acquiring full or partial control over another country, exploiting it economically, and imposing cultural values, deeply affected indigenous traditions. In Africa, cannabis had long been cultivated and used in traditional medicine. But when the British came, they declared it dangerous, not because of evidence, but because it was tied to African identity. In Nigeria, South Africa, and Kenya, colonial authorities banned local substances while importing their own: alcohol, pharmaceuticals, opiates. These bans were often justified under moralistic or paternalistic arguments, even if racially motivated. In 1933, colonial Kenya criminalized cannabis under British law, and decades later, independent Kenya still uses that law today. This is what we mean when we say drug control is colonized. These aren't just laws, they're legacies. For example, cannabis arrests are still common, and courts continue to prosecute under these outdated laws. Let's talk about the United States, because its influence shaped global policy. In the 1800s, opium was legal. Morphine and heroin were sold over the counter. In fact, during the Civil War, so many soldiers became dependent on morphine that it was called soldier's disease. But drug use only became a moral panic when the users stopped looking like white middle-class Americans. A moral panic is a widespread fear, often irrational, that someone or something is a threat to societal values and interests. When Chinese immigrants brought opium smoking to the West Coast, they were quickly targeted. In 1875, San Francisco passed anti-opium laws not because of harm, but because white citizens feared Chinese culture and labor competition. Similarly, cocaine was linked to African American men in the South, with racist myths suggesting it made them superhuman and violent. These lies laid the groundwork for criminalization.
It's important for students to understand that these early laws, like the Harrison Act of 1914, didn't actually ban drugs. They taxed them, but in practice they were used to arrest physicians who continued maintenance treatment and to punish users, mostly black, Chinese, and poor. This was the beginning of the war on people under the guise of a war on drugs. The public wasn't afraid of drugs, they were afraid of who was using them. That's why the same substances, when used by white people, were medicalized. When used by black and brown communities, they were criminalized.
So what do we see when we pull back the curtain on the history of drug use? We see that drug policy has never been about substances alone. It's been about identity, power, control. This isn't just a chapter in U.S. history. It's a mirror held up to global systems of inequality. As we move through this series, remember, drug use isn't new, but the decision to punish it, selectively, violently, racially, is. If the history of drug use is ancient, the history of drug control, as we know it, is modern, political, and often hypocritical. Let's zoom in on three pivotal moments: the temperance movement, prohibition, and the Harrison Act of 1914. These weren't just laws, they were tools of social control. The temperance movement began as a moral campaign in the 1800s, but let's be real, it wasn't just about alcohol, it was about class, gender, and ethnicity. The drunkard in the American imagination was usually a poor Irish Catholic man, portrayed as violent and lazy. Protestant women led the charge, arguing alcohol destroyed families, and while that's partly true, temperance was also code for assimilation, make immigrants more like respectable Americans. Temperance, by the way, means moderation or self-restraint, especially in drinking alcohol. By the time we reached the 18th Amendment in 1919, we'd made it illegal to produce, sell, or transport alcohol. But what was called prohibition was really the government's first war on drugs. And like all wars on drugs, it was a disaster. During Prohibition, alcohol didn't disappear. It just went underground. Speakeasies thrived, organized crime exploded, corruption infected law enforcement, and perhaps most ironically, alcohol-related deaths increased because people were drinking toxic, unregulated booze. So much for public health. It was a case study in unintended consequences, something we still see in drug policy today. But before Prohibition was even passed, the U.S. laid the groundwork for policing drugs with something even more foundational, the Harrison Narcotics Tax Act of 1914. This law was supposedly about regulating opium and cocaine, but what it really did was make addiction a crime. Addiction was seen as a moral failing, a personal weakness rather than a medical condition. And let's not forget who it targeted: Chinese immigrants who smoked opium and Black Americans supposedly addicted to cocaine. White doctors and middle-class patients using morphine, mostly left alone, at first. Here's what's wild. The Harrison Act didn't actually ban drugs. It taxed them. But if you didn't register properly or were suspected of misuse, you could be arrested. And that's exactly what happened. The law quickly turned into a tool for the government to go after marginalized communities, particularly Black people in the South and Chinese immigrants in the West. This marked the first time drug addiction transitioned from being viewed as a medical condition to a moral failing and criminal offense. Let's pause here, because this is a pattern, a cycle, a ritual. First, a substance is associated with a marginalized group. Second, moral panic erupts. Third, lawmakers criminalize it, not to protect people, but to control who uses it. Global strategies of drug control have long been influenced by colonial powers. Dr. Kojo Koram explains this dynamic. Exactly. And this wasn't an American anomaly. Globally, we see the same strategy: colonial powers identifying which substances are uncivilized and which are acceptable. Coca leaf, opium smoking, cannabis in India or North Africa, demonized. But alcohol and tobacco, commodified, taxed, embraced. It wasn't about the substance itself, but rather about who was consuming it. The focus wasn't just on the substances themselves. It wasn't about the drug, it was about the individuals who were using it. Race has often been the driving force behind drug policing, particularly in the United States. Even within the United States, race was the driving force behind what got policed. By the 1930s, newspapers were running headlines like, "Negro cocaine fiends are a menace." These racist myths fueled panic and justified harsh laws. The same thing happened with Mexican immigrants and cannabis in the 1930s, leading to the Marijuana Tax Act of 1937. So let's review what we've learned. Temperance and prohibition weren't just about health. They were about morality, ethnicity, and control. The Harrison Act marked the beginning of the criminalization of addiction and disproportionately harmed Black and immigrant communities. Drug laws have always reflected who society fears, not what science says. And as we'll see in the next section, these policies didn't fade, they evolved. Part 3. Shifts in public perception and legal status over time. Perception is power. What the public believes about drugs and who uses them has shaped every law, arrest, and health policy we've discussed so far. In this section, we explore how those perceptions changed, and how those changes weren't organic. They were constructed by media, politicians, and fear. Let's take a closer look at the U.S. opioid epidemic. When white suburban youth started falling in the streets of heroin overdoses, headlines called it a tragedy. When black people were arrested for the same behavior, it was a crime wave. This racial coding in the media isn't new. In our study, we saw how white opioid users were painted as victims, hooked through prescriptions, failed by the system, deserving of treatment. Black and Latino users, portrayed as dangerous, criminal, or already lost. This perception gap has created what we call narcotic apartheid. Two parallel drug policies, one medicalized, one criminalized, based on race and class. And this isn't just about opioids, it's part of a long tradition of drug scares. Each decade has its scare. In the 1920s, it was black men on cocaine. In the 1930s, it was Mexican immigrants and marijuana. In the 1980s, it was black crack users. And by the 2000s, it became suburban white teens and OxyContin. Each wave didn't just shift public perception, it shifted policy. And that's how you get things like the 100-to-1 sentencing disparity between crack and powder cocaine. Same drug, different people, vastly different punishments. And remember, these shifts are global. In the UK, cannabis went from widely tolerated in the 1990s to reclassified as a Class B drug after a moral panic in the press. In the Philippines, President Duterte launched a violent campaign against drug users, portraying them as subhuman. Thousands were killed in what was framed as public cleansing. The emotional framing, fear, disgust, pity, is what drives the law. Let's talk about moral panic. That's a sociological term from Stanley Cohen, describing how societies amplify fear around a perceived threat, usually aimed at marginalized groups. Drug users are the perfect scapegoat. They're already stigmatized, easy to isolate, easy to dehumanize. The media helps create folk devils, symbols of what's supposedly wrong with society. In the 80s, it was the crack mom. In the 2010s, it was the pill-popping teen. These images don't appear by accident, they're engineered. Folk devils are those individuals or groups who are portrayed as outsiders and deviant, blamed for crimes or other societal problems. One thing that's fascinating and deeply frustrating is how quickly public opinion can shift when white people start to get hurt. In the 1980s, crack was demonized. In the 2010s, oxy was medicalized. Same mechanism, different population. And that's when politicians finally started talking about harm reduction, overdose prevention, and compassionate care. This shift in perception also drove legal reclassification of drugs. Marijuana is a great example. Once vilified as the assassin of youth, it's now a multi-billion-dollar industry, but mostly in white hands. Meanwhile, people of color remain incarcerated for doing the exact same thing a dispensary does today. This selective memory is a form of erasure. It says, "We've changed," without repairing the harm that was done. Globally, we see countries backtracking from hardline policies. Portugal decriminalized all drugs in 2001. Canada has moved towards safe supply. Even Colombia has tried to reduce punitive cannabis laws. But it's not just about policy. It's about how we talk about drugs. Are we talking about health or crime? Are we talking about healing or punishment? That shift in conversation reflects a deeper cultural reckoning. So, what do we take away from all this? 1. Public perception doesn't just follow policy, it shapes it. 2. Racial and class stereotypes guide how drug users are seen and treated. 3. Media, politics, and fear-mongering create the emotional fuel for laws. 4. Compassionate policies tend to arrive only when the dominant group is affected. In the next section, we'll examine how U.S. drug policy developed into the 21st century, from the Nixon administration to mass incarceration, from zero tolerance to harm reduction. Policy into the 21st century. As we move into the 21st century, one truth becomes clearer and clearer. U.S. drug policy isn't just outdated. It's a historical snowball of fear, politics, and power that continues to crush lives, particularly in marginalized communities. So how did we get here? Let's go back to 1971. President Richard Nixon declares drug abuse public enemy number 1. This marks the official start of the war on drugs. But make no mistake, it wasn't a war on substances. It was a war on movements, on people. We now know from Nixon's own aide, John Ehrlichman, that the war was strategic. Quote, "The Nixon White House had two enemies, the anti-war left and black people. We couldn't make it illegal to be either, but by associating the hippies with marijuana and the blacks with heroin, and then criminalizing both heavily, we could disrupt those communities." That's not just law, that's political weaponry. The 1980s, everything worse. Under President Reagan, the war on drugs escalated. Funding shifted from treatment to enforcement. In 1986, the Anti-Drug Abuse Act introduced mandatory minimums, most infamously the 100-to-1 sentencing disparity between crack and powder cocaine. 5 grams of crack cocaine, 5 years in prison, 500 grams of powder cocaine, same sentence. Crack was associated with poor urban black communities, powder, white suburban users. The result? A legal double standard that devastated generations. And media was complicit. They gave us the image of the crack baby, the crack mom, the super predator teen. None of it supported by science, all of it drenched in racism. These images were used to justify police raids, surveillance, and mass incarceration. Today, over 2 million people are incarcerated in the U.S., and nearly half are there for nonviolent drug offenses. Drug laws became the pipeline that fed the prison industrial complex. Then came Clinton in the 1990s. People hoped for reform. What they got was more criminalization. The 1994 crime bill added more police, more prisons, more punishment. Drug courts emerged as an alternative, but often still forced users into coerced treatment under threat of incarceration. And yet, the science didn't change. Addiction was still a health issue, but the policy, still punishment first. Meanwhile, other countries were shifting. Portugal in 2001 decriminalized all drugs and focused on harm reduction. HIV infections dropped, overdoses dropped, drug use didn't spike. It proved what we already suspected. Decriminalization works when it's backed by support systems. But the US? Still stuck in cycles of criminalization. Then, something ironic happened. As opioid addiction began to rise, this time among white middle-class communities, the narrative changed. Now, addiction was a disease. Now, users were seen as victims. Now, the solution was treatment, not prison. But where was that energy in Harlem in 1985? In East LA? In Detroit? This racial divide in empathy is policy in action. Harm reduction is a set of practical strategies aimed at reducing negative consequences associated with drug use. In the 2000s and 2010s, we see marijuana legalization explode, first medically, then recreationally. But the people profiting? Often white entrepreneurs. Meanwhile, black and brown folks still sit in prison for possession. This is not justice. This is gentrified drug policy. Decriminalization means reducing or eliminating criminal penalties for drug possession, shifting the focus to treatment and education. So where does that leave us? The war on drugs was built to control, not heal. Mandatory minimums and policing reinforced racial hierarchies. Media helped script public perception and public fear. When the opioid crisis hit white America, only then did policy soften. Today's legal cannabis industry profits from a plant that once justified incarceration. As future psychologists, educators, or clinicians, you need to ask, are we responding to data or to demons? Are we building systems that heal or ones that punish? Join us in the next unit as we dive deeper into the biology of addiction. Because to change policy, we need to understand people. And to understand people, we must understand their pain, their context, and the systems wrapped around them. Until next time, stay curious, stay critical, and keep asking who the law is really